listen-only mode.
Good afternoon, everyone. This is Alex from Okasi. We have today here Angela with me and also Marylin. Before we go to the presentations, I just wanted to make sure that we have some ground rules for how to use this webinar system. Can you hear me first of all? If you can hear me, can you please use the chat box on the right hand side and say yes? Yes, okay, yeah, receiving, good. Perfect. So now we know how to use also the chat box. Now some of you will have microphones hopefully. So you can either use the microphone or the chat box to ask questions and to make comments. If you have a mic and if you want to ask a question, you can raise your hand. So there is a button on your right hand side there. If you have a question, you can raise your hand and I will unmute you. By default, everyone is muted to have better audio and to avoid distractions, okay? If you do not have a mic, you can always continue using the chat. Marylin is okay. If you have questions during the presentation, you can stop and ask questions at any moment in time. Marylin will answer the questions. Other than that, Angela, as you know, has facilitated many of the Embracing Inclusion institutes throughout Ontario, so I will leave the floor open to Angela right now.
Hi everybody, Angela Connors here. Thank you so much for taking time out of your day to join us. I'm really excited about this webinar and particularly having Marylin Kanee here, the Director of Human Rights and Equity at Mount Sinai Hospital. Human Rights and Equity Office developed the Are You an Ally campaign, which I've taken a look at and is really exciting. And so we're going to get right into the webinar shortly. As Alex mentioned, there's a number of ways that you can interact with us and ask your questions. Just in the few minutes that I've had an opportunity to chat with Marylin before we started, I can tell you she has a wealth of information, so please feel free to chime in with any questions. I'll hand it over to you, Marylin.
Great, thank you, and thanks Alex and Angela for organizing this and for inviting us being the hospital, myself, to come and speak about our experience in developing a Human Rights and Health Equity office and program at Mount Sinai Hospital, and now we are currently joined with Bridgepoint Hospital, so we're a Sinai Health System. I can't see any of you. I don't know what your interests are. I want to thank you all for tuning in today, and please do ask some questions if you if you find that the content isn't as useful as you'd like it to be. Certainly we can have more of a discussion. So we're going to go through a number of slides and leave some time to, at the end, about 15 or 20 minutes, to make sure that we can have a broader discussion. But again, please do raise your hand or ask a question on the chat piece if you do have something you would like to address or talk about. So actually, you can't see is something that I got in the, we can start to go through here, but is that something that I received on my computer yesterday, and you may see these all the time too. It's one of these magazine articles that says diversity programs don't work and a new study shows why. And they're always a bit discouraging and depressing, and they usually have some answer that's going to tell us, something new that's going to make all of our programs work, and we're going to have equitable organizations, but we don't necessarily find that those are going to be the answer. And I think what we want to talk about today is, what can work, what can create greater equity within organizations, and also how important it is, because workplaces and the places that we provide services are really important places for us to try to lead change within our whole society. So one of the reasons that programs don't work often is because of what's actually going on outside of our organizations, and that's in the broader society and the forces that are there to not really support equity. But again, within organizations, there's some space for us to do things that can make a difference and have an impact in the broader society as well. So in this slide, you'll see our vision, and the vision that we have actually acknowledges a legacy that both the hospitals that now form Sinai Health System have, and that's a legacy of really providing care and services to marginalized populations, and actually in Sinai's case also providing work opportunities and learning opportunities to, at that time, Jewish physicians who were actually not able to practice in other hospitals. So that and that Bridgepoint was founded as a tuberculosis hospital, and it was actually across the river in Toronto, where so sort of put aside very marginalized populations as well. So we really try to build on that legacy, really talk about the roots and what's important about these hospitals and how they were founded. You can see the goals that we have, and those are goals that, if we achieved all of that, we would really know that we were getting somewhere, that the program, maybe our diversity, equity strategies were working. And they're pretty broad, and that means that really everything that we do in our hospital would have at the center of it equity and human rights. That any patient who would consider coming to our hospitals would, and maybe think about, would I feel welcome there? Will I get equitable care? Will I get treated with dignity and respect? They would go, oh, of course, I'm going to Sinai Health System, so of course I'll feel included, and I'll be well cared for and have the best possible care. And we do want to be a leader around human rights and health equity, and ultimately reduce health inequities to provide better health outcomes. I know that you're not all from the healthcare sector, but I really do want to talk about health equity because of course it affects all of us and affects the clients who you serve as well. Some of the ways that we do that currently are through what you see on your slide there is through awareness and education. Those are some of the programs that we have around awareness and education. We have challenges currently because the education opportunities within the hospital have been diminished. So now we do a lot of what we deliver. We try to find other ways to get in touch with staff, and that might be in their huddles in the morning. It might be through posters that we have throughout the organization, through communication from our communications department. So we look at a whole range of ways of actually doing awareness and education, not only in person and online education. These are the policies that our office has created and that we are responsible around. So you can see we cover we actually, our HR and HE policy, which is human rights and health equity, is a very comprehensive harassment and discrimination prevention policy, but it also lays out the goals of our office in terms of the kinds of organization we want to become. So consequently it's a 26-page document, but it does have all the information that you'd need if you wanted to file a complaint or if you were actually respondent to a complaint as well. We have an equitable hiring policy that we developed with Human Resources, a code of conduct. We have a very rigorous domestic violence program that applies not only to staff but to patients, and we also do have an accommodation policy, and as you see, gender identity and gender expression. And if you are looking for a healthcare-based policy around gender identity and gender expression, you can find that policy, which is a model on the Rainbow Health Ontario website. Leadership, and we'll come back and talk more about that, but obviously a commitment from leadership in terms of resources and support is essential if we are going to, for a program that actually will work. And then what you see in terms of respectful, equitable, accessible hospital is part of our function is to deal with complaints. We get about 125 either serious harassment or discrimination complaints in the hospital each year, and we deal with those mostly through informal processes where we maybe bring people together, we do training, restore the environment in a number of ways, but we also do investigations as well. And then the other piece that is so critical to this is really figuring out, again, what does work and what's happening in our organization. And for that we do research, and we'll talk a little bit about that, some of the things that we have tried and that have actually been really helpful to put before senior management in the organization to say, for example, this is how staff are feeling. These are some of the things that people are expressing, and here are the 15 things that we feel that we need to be doing to address the situation with staff. So what you'll hear, what I want to talk about is both how we take care of the people who are providing services in our organizations, how we ensure that they're in a respectful, accessible, equitable, and safe environment, and also how we make sure that we provide that for our patients and clients. And what I was thinking when I was in a cab coming over to do this presentation, I was thinking about, what would tell us that this work is working? So, this responding to that diversity programs don't work. So what would tell us that it's really working? So besides those goals being realized that you see there, I think what we'd want to see is really that all staff have opportunities for all work that they're qualified for in the organization. And that would also include educational opportunities, like getting access to sitting on committees, getting sent to conferences, learning to do things, being mentored, being supported, being thought of as folks who can do anything in the organization and therefore are, really worth nurturing and bringing along in the organizations. I think we would see that all patients, again, know that their specific needs, and those would be around language or disability or gender identity, sexual orientation, race, etc., would be provided for in our organizations, and that we would be interested in all of who they are, and we would ask questions about that. And also that we would have equitable health outcomes, where we as service providers can have an impact. So I'm going to talk about that because we are not able to necessarily address all of the social determinants of health from our organizational roles. But what can we do? Where do we have responsibility around those? And then finally, it's accountability if these things aren't happening, and that's so critical. And that is often the missing ingredient in terms of maybe why sometimes programs don't work. And that accountability has to be quite as serious as any other accountability in the organization. And along with that, of course, comes leadership who are accountable and hold others accountable. Thank you. So in this slide, maybe if you just look at it for a moment, you can think about what does this slide actually say to you. And if you have some thoughts around that, feel free to share them on the chat. But basically, what we see in this slide is that health, underneath health, are all of the social determinants of health, and these are just some of them. I mean, you could, I'm sure, have others that you would add to that list. And what we're talking about here is how, also, if we can actually click that again twice for us. Thanks. You'll see these are the areas that we actually, certainly in a hospital, can control for. One is access to services. And Alex, if you click that again, you'll see the other piece that we can, which is how we treat people when they come, when we have contact with them. Is everyone treated with respect and dignity? So we'll come back to that and all of these as well. But these are the two pieces that we can really control when we look at the social determinants of health and ultimately how that creates health. And when we talk about healthcare access, we're really we're talking about being able to receive care when you need it, and also where, when you need it and where you need it as well. Being really inclusive culturally and linguistically, being there when you need it, and of course being affordable. And we know that more and more, really, to be healthy in our society and to stay healthy, or if you unfortunately do experience an accident or illness, that it does take, the better your income, the more likely you are to have a better recovery. These are just some of the health inequities, I wanted to share with you. And of course, you are all aware of many of these, and you see them every day in your work and the impact of these. But these health inequities that even, I think are just more and more being talked about, because I think we assumed that with having a Medicare system in our country that these didn't exist, that everybody has access to care. But as I mentioned, it is the social determinants of health, and we'll look at that at the next slide actually, that have the greatest impact on people's health status. So in terms of what makes people sick, you see 50% of that is our lives, and 25% is healthcare, and that's the space that I believe most of us are working in there, is really looking at providing around the social determinants of health, addressing those, and then for us, I work in an acute care hospital that now has a rehab facility as well with Bridgepoint, but we're really looking at access to the healthcare system and what kind of care we provide in our healthcare system. Again, how accessible it is, how it is tuned into the range of needs that people have depending on their identities, and then of course wait times. And those are all impacted by people's identities, including wait times. So we'll talk a bit more about that. This came from the Canadian Medical Association. flip along. So when we look at, again, for those of you who are providing healthcare services, and I think some of this applies in social services as well, is that we don't have the opportunity necessarily to impact all the social determinants of health. That takes all of a society to do that. But where it does come in is in that access to healthcare piece. So we're not only talking about physical barriers that might exist in addressing those, we're also talking about ensuring that people receive the same information and can provide the same information to their healthcare providers as anyone else. Sorry. In addition, so when we look at access, sorry, we're having, I think, some great. There. Just solved a technical difficulty here. So when we look at access to healthcare, it's much broader than just the physical, but the physical is also very important, and it also refers to things I'm sure many of you think about or are tending to, is what's on your walls, what's in your waiting rooms, what kinds of reading materials, what kinds of photographs, who is seen to be important in your organization, and there's all kinds of ways that we can say to people, you are welcome here, we expect you to be here, and we're going to treat you always with dignity and respect. Then we get to how we do treat patients and each other, and that is ensuring that really everybody does receive respect and dignity. And again, we have data and information that says in the healthcare encounter that does not always happen, and that is because we are just like everyone else in society. We have assumptions and beliefs about who we are and who we think other people are, and those assumptions and beliefs in many roles, if you think of teachers, if you think of police, and if you think of healthcare providers, can have very serious impacts on ultimately people's health outcomes, because people may have differential diagnoses, may have differential treatment, and ultimately differential health outcomes as a result of that. And then so importantly that we do research and evaluation. And again, research doesn't have to look like something very formal with a report, but it's always asking, are we always asking staff how they're doing? How do we do that? Are we surveying? Are we creating safe spaces for people to be able to talk about what is it like to be them in this place? And what can we do to make that better for them? We did quite a number of years ago, we actually did focus groups with staff that were very involved. It was a process where there was a lot of activities, but it allowed people to talk to one another, and I think allowed people to do that in a way that they felt comfortable. And we did that by identity groups. So we had a group, for example, of racialized managers, we had people with disabilities, we had very frontline staff, the folks who were cleaners and service assistants, and we heard from them about how they experienced the workplace environment. We actually had something like 40,000 quotes. As a result, we analyzed that information. It took us 5 years because we did it sort of off the sides of our desk, but we ended up with some really powerful material and themes that emerged, and out of that, again, we made recommendations to senior leadership. It doesn't have to be that complicated, though. I think it's around really making sure we have regular mechanisms to check in around that, and again, of course, with our patients. A lot of our patient surveys out of hospitals, most of them, they're in English. So we're missing large portions of the population where it's very important that we hear from. So I think there is in the works now more emphasis on making sure that the surveys are also accessible, and the ways that we evaluate our programs are accessible as well. This is a definition of health equity that was created by Health Quality Ontario and just came out this year. So I think, again, it's all that we're talking about here. It's achieved when people are able to reach their full health potential and receive high quality care that is fair and appropriate to them and their needs, no matter where they live, what they have, or who they are. And of course, when we do that, we actually create high quality care. And there's lots of research out there that talks about that we can improve healthcare in general when we make improvements for people who are in marginalized populations. So if you even think about simple things that you might do in your environment to create access for people with disabilities, many people often benefit from those. So we're going to move on to talk a bit about what we do at Sinai Health System to create a respectful, equitable, and accessible hospital environment. And one of the things, I'm not going to talk about our complaint process because that would be a very long presentation on its own, but I do want to say that we use the complaints to make systemic changes in the organization. We look at each one as a learning opportunity. There's something that isn't working for people, and it may not have actually been discrimination, but there's a perception there that something did happen that wasn't okay, and how can we make sure that doesn't happen in the future? So as an example, interactions that we've had probably more complaints over the past while from people who are trans, and as an example, not only trans people, but people in many marginalized populations may experience something that we do every day with all patients without thinking about it, but they may experience that as discrimination. So one thing that may happen is, for example, you would see a student, you would see a trainee when you come to the hospital. Probably many of you have had that experience. So you see the resident or you see a medical student, they do your history, and then the doctor who is supervising them comes and joins in the discussion, and you actually have some time with them. But if you're not aware of that, if that's not explained to you carefully, you may feel that you're getting second-class treatment or inferior care or treatment because you're seeing somebody who's a trainee. So these are really important learnings for us. So we then put in a campaign where we're educating folks around how they introduce themselves, posters that explain that you may see a trainee, and you also will see the physician at some point. So that this is just part of our day-to-day process in a teaching hospital, but if we don't explain it, it can actually seem discriminatory to people. So that, again, that's just a small example of some of the learning that we have. You can continue here. These are some of the events and some of the activities that we do to promote learning in the hospital. So we have a lot of annual events, and those annual events may have anywhere from 20 people to 100 or more people, but we do them also because there's information then around the hospital about them. The fact that we think they're important, we do display in the lobby, we leave it up so people go by, they read more about it, and basically it's saying these are important, it's important for us to have this information. As healthcare providers, it's always health related, healthcare related in some way, so we always focus around that. Then around committee, we have a number of committees that are subcommittees of the Human Rights and Health Equity Committee, and you can see some of those that exist there as well. And then we do internal presentations and training throughout the hospital. We do them, we customize them, we do a lot of follow-ups to complaints that happen in the hospital to make sure that in that area people understand what the expectations are, or what did we learn from this, how do we make sure that we share that all the time back with the individual area. This is a study that I wanted to share with you. It did come out in 2002, but it was very important when it came out. It's a meta study. It looked at all of the studies that have been done on what they called ethnic and racial minorities. And what they concluded is put very, very, very gently, and it says that they concluded that even when members of minority groups, and again they're referring to ethnic and racial minorities, have the same incomes, insurance coverage, and medical conditions as whites, they receive notably poor care. Biases, prejudices, and negative racial stereotypes, the panel concludes, and again, very gently, may be misleading doctors and other health professionals. So basically they're saying that, our assumptions and our beliefs, and this is, I think, very relevant in Canada because, as you see, they controlled for income, access to health care as well, because this was insurance coverage, and the same medical condition. So very, very thoughtfully done. It's a 1,600-page study, actually. And they're basically saying there's something about us in this healthcare encounter that is leading to poor health outcomes for racialized people and other ethnic minorities, and it also includes higher levels of mortality. Nobody goes into healthcare to hurt people. And that's very compelling information when we put this in front of folks, because nobody wants to be doing anything that's hurting, and yet inadvertently that is in fact what is happening. So we developed, as Angela mentioned, an ally program, and the reason that we developed it was we find in healthcare, and you may find this as well, but certainly in the hospital, what really struck me is the way people deal with every day the most difficult, complicated situations. They bring a team of folks together and put their, kind of bright minds together and come up with these amazing solutions. And they have very, pretty respectful and complicated discussions about that. But when it comes to talking about the issues we're talking about today, about equity and race, gender identity, sexual orientation, etc., the conversations do not happen in that way. They tend to be quite emotionally charged. Mm-hmm. And we were looking for a way of really harnessing that way that people can interact and talk about all these very difficult issues that come up in healthcare, but do that around the topics that we wanted folks to talk about as well. And so we created this campaign called Are You an Ally? And we found that that did not raise the same kind of defensiveness in folks as a way to have discussions about doing this work within the hospital. And also it got people really engaged, and it also helped people to talk about privilege and start to recognize and address the privilege that we have, those of us who do have it, and also as healthcare providers vis-a-vis our patients, the kind of privilege that we have. So this is an example. We have 5 pillars in that campaign. We have disability, physical disability, we have mental health issues, we have race, LGB, and trans. So we did those 5 pillars, and we created materials and videos on each of those areas, and we involved folks from the hospital, and we involved patients in the making of those videos as well, and did a lot of thinking about and a lot of back and forth around what could we put in a 10-minute presentation, because we don't always have the voices in the rooms where we're doing training, and we thought it would be so important to have people with lived experience talk about that. So this is some of the information that we have around that, and Ally acts when people face discrimination and supports the rights of marginalized people. And that really the idea is anybody in the hospital can become an ally. We have ally, you see the little ally button there. If you come to our training, you get a button. And so we have done this training in particular departments and units throughout the hospital. We usually follow up complaints by doing this work, and it hasn't been rolled out in a completely systemic way, but we're certainly hoping that we can do that much more so. And it's also a part of our management training on leading equity. So there are, again, 3 steps to becoming an ally, and that is, as you see, understanding one's own feelings, and that's so important because, of course, we tend to forget about ourselves as part of the healthcare experience for patients, and then understanding the issues involved, and finally building skills in folks about how to respond appropriately. So we actually practice how do you intervene if your colleague makes a statement or a comment about other people that is discriminatory, and that may be about a patient, that may be about a family member, it may be about another staff person in the hospital. What is the role that all of us as people who work in this organization have around addressing those situations? And people actually started talking in the hospital about that's not ally language. So we also do tips each month. So when you saw that list of activities and events that we observe in the hospital, we do what we call ally tips of the month, specifically around what might be a key issue. So for example, during Black History Month or around Lunar New Year, we would put out tips of the month around racism and how to support your colleagues and patients who may be experiencing racism. And they're very simple, as you saw, very, very brief and very simple and very operational within the hospital environment. This is our website. If you haven't seen it, please do visit, and you can see that the resources that are available at the bottom of the page. And again, if you have any questions or comments about it, please contact us, and we'd be really happy to talk to you about it, and love to hear your feedback as well. And then I wanted to talk about research, measurement, and report. And in healthcare, evidence is everything. It's so important if we want to, bring people on board and get their support around this, is providing evidence. And I actually had a revelation once around a VP who I wanted to engage, and I thought, I'm trying to say, but this is not fair, and this is the right thing to do, and we did a little exercise around kind of, our one of those exercises, just a quick one around, your predominant go-to. And so mine was emotion, and I looked across the room and she was standing in data. I thought, that's what I haven't been doing. And taking that approach of putting data in front of people, and again, I'm sure that you all know that as well, can make such a difference. So we do need to measure, and we do need to keep doing different kinds of research and looking at how we can, how are people feeling, what's the impact when we do implement something, is it making a difference? And that's not like shooting an arrow and having it land somewhere. The work that we do in trying to create equitable environments, it's not that easy to measure. So basically what you want to keep looking at is, how are people doing, and what else do we need to be doing to ensure that this is really an equitable environment? And sometimes you can really see if things are working. So maybe we can just take a look at some of the pieces that we've done. So we did a workforce census. We've done it twice now. The last one that we did in 2013 is evergreen, and that means that people can keep updating it at any point, and we can keep introducing new staff into that. So it's looking at all of the sort of key areas of identity and asking folks about that. We also did what we called an inclusion survey, where we could stratify the information, like how included people felt in the workplace environment, by those demographic variables that we were collecting. And so we did see that there were some differences across staff groups. They weren't hugely significant, but it did allow us then to say, we're going to target, we're going to do some work in those areas, because we know that staff are not feeling as supported or as included by their leadership, for example, as other staff in the organization. Then we also collect patient demographic data, and there's the reason that we do that is because we were only able to figure out who our patients were by putting them on a map through postal codes. We did not have demographic data beyond sex, birth assigned sex, and I'm just thinking, and age. That was it, and their postal code. So that happened about 7 years ago, and because that was the case, 3 hospitals, Mount Sinai, CAMH, and St. Michael's Hospital got together, and were later joined by Toronto Public Health, to do a research study on how we would actually collect demographic data and what would be the most important variables to be asking patients in order to achieve health equity. And that turned into a 3-year research project, mostly because we weren't really researchers. We were kind of policy people and leading this work within our organizations, but we really did not appreciate how complex this was. And at the end of that, you'll see we came up with a report, and I'm going to cover more of that a little bit later, go into more detail around each of these, that led to the Toronto Central LHIN mandating patient demographic data collection in 17 hospitals and 17 community health centers, and we are leading that project and supporting the hospitals and community health centers around that. And then further research and applications, we're looking now at really doing some research around how do we use that data in care, because there's nothing really out there that helps to guide us around how, as clinicians in the front line, how do you use this information about people's identity to actually provide the care that you're providing? What questions would you ask? How might that change the process? Thanks. So I want to talk a little bit about our workforce census. So you can see some of the key findings from this. We figured out 76% of the hospital's workforce identifies as female, for example, and what we had seen previously was 85%. And then we see some of there are 91 languages that were spoken in our hospital at the time. 45% of our workforce were born outside of Canada. So we're going, okay, we're kind of in line with the city of Toronto around that. But then there's lots of ways that we weren't as well. And that's largely in terms of representation at leadership. Can we click again on there? Thanks. Thank you. And so we shared with people to engage folks around filling out the census the second time. We asked folks, we said, these are some of the things that we have done last time, based on the information that you provided us when we did a sort of snapshot of the hospital. There were some initiatives that we took. Still, we only got in that survey, that actually, when we surveyed folks, but it is the Evergreen system, we got about 50% of the staff, and of course we want to have everybody, and I think that we have some strategies and thoughts about how we're going to do that going forward. Okay. Measuring health equity in the TC LHIN hospitals is the project that we lead, and as you see, there's the research report, and here's what it identified. It identified key patient demographic variables. So what, if we want to achieve health equity, what are the most important pieces for us to measure? There are other really important things that hospitals often do ask and can ask. For example, religion was optional, housing was optional, but we wanted to keep it to no more than 8 questions because we knew that we couldn't likely engage hospitals around collecting more than that. And we also wanted to be really key that what we want to do with this information is link it to the health outcomes that we have in our healthcare institutions. And that can be all kinds of things. That can be things like wait times, that can be who gets medication and what types of medication, it can be birth weights, when babies are born. There's so many outcomes that we want to link and stratify this data by that we can learn so much from. And then we wanted to look at what would be the most effective ways of collecting this data, and then we also then started to look at how we would actually train folks to collect this information and do that. What we learned from that was that you've got to start somewhere. And so if we wait until everything is perfect and we have the perfect questions, and I can tell you I don't think such a thing exists, you'll never get started. So not to get bogged down with, are we doing this right? Is this the absolute best it can be? You need to start somewhere with and I think that applies to all of this work that we're trying to do together. We found that patients were more than willing to respond. We had over 80% participation, and we continue to see that patients are more than willing to provide this information. In fact, lots of people are saying, like, thank goodness you're asking me. I'm so glad. And it's not left to me then to have to disclose my sexual orientation or, the fact that I don't have an income that could actually pay for the medication that you are prescribing for me. We found that we needed strong commitment from leaders, once again, and that training of data collectors was the absolute key to having this work. If people understand the importance of having this information about patients, what they are contributing to health equity by asking these questions from patients, they don't get as engaged. But once they know that, it makes their job often more interesting. A lot of the folks who are collecting are in admitting departments, at registration areas, and they can get very engaged. The reluctance, if there is any, is coming from the data collectors, asking questions that they feel are personal, that they feel are sensitive, which we keep explaining. We ask a lot more sensitive questions in healthcare than the ones we're asking, most of which is, can be fairly evident, but we absolutely self-reporting of this information is critical, how people describe themselves. We're not looking for medical information here, we're looking for how people identify themselves. And finally, IT can be extremely challenging part of this project, and that's a whole other long discussion, so I won't go into that now. These are the questions that we ask, and some of you may already be asking these questions, and we try to link the questions in our workforce census to these as well, because then we can see whether our staff reflects our patient population, and where are the similarities and where are the differences there. So if you look at that, you might think about which question you think patients would be least likely to answer. So I'm not sure, because I'm not hearing from, I don't know what you're thinking, but most people think it's sexual orientation and sometimes gender identity, and in fact it's income. It is income, and probably a lot of you did think that as well. So so what we did was we organized these questions in order from what we thought people would be, what they showed us actually, they would be most likely to answer to least likely to answer. And that was something we didn't do the first time we did our workforce census. We started with sexual orientation, so that was not a good idea at that time. So really starting with what people have an ease and a comfort with is a good idea.
It's Angela here. I'm just chiming in because I have a question around the data collection when you started doing it for patients. Was there any surprises, like things that really jumped out and said, wow, we didn't expect that?
Well, I mean, I think IT was a big surprise because I mean, I think it's good we didn't know. I just thought you put information in here and then it comes out here and you link it to here. So I don't think we would have even begun this journey if we had any idea of how complex our IT systems. We have folks putting really fabulous data into systems that they can't pull out. Or that they can't link to health outcomes. So they're challenges, but we kind of are working through these one by one, and there are many different ones because we're working with a lot of different IT systems and a lot of different organizations, CHCs and hospitals, and nobody's pretty much doing the same thing. So those are big challenges that we have. But beyond that, we get really, really few patient complaints. And mostly it's because it maybe wasn't explained to them as thoroughly around what is the purpose for us asking these questions. People, I actually am surprised always at how willing people are to provide this information when they know two things. One, it's around increasing equity, and people really do want to see that happen. And the other piece is around improving the quality of care. And when we do, again, when we do address health inequities, we increase the quality of care for everybody. So within the TC LHIN, the Toronto Central LHIN, we had the report that we've talked about. We Ask Because We Care research report. In 2013, hospitals started collecting the patient demographic data, and then we've expanded it, and actually the target at this point is 75% of all patients will be asked these questions. And everybody has the right to prefer not to answer, or actually also add, and most of the questions have other as well. These are the kinds of tools that we have provided, and the support that we've provided through our office for hospitals and community health centers to implement the project. And almost all of this material is on our website, and I'll give you that link at the end as well. And just, I thought, one example of how we stratify. So this is a quality indicator. An ALC is how long people spend in hospital, how many days people spend in hospital over what is expected for their treatment, their condition and treatment. And so this, in our own hospital, one of the findings was that compared to 12% of English speakers, you can see that basically double the number of Chinese and Italian speakers spent time as ALC patients. So that raises more questions. Exactly what is happening there that is creating that situation? Is it that people are not getting communication that they need? Are people looking for specific kinds of placements outside of the hospital that would meet their needs? Many questions. Those are just a couple. I'm sure we can generate many. Are they not getting the same care as other folks in the hospital? So we don't know what contributes to it, but it does help us, it's something to look at. And there's a lot of incentive in hospitals because hospitals are penalized for ALC days. They're penalized financially. So there's a lot of incentive in addressing these issues. So when there's that kind of synchronicity, I guess that's a good thing. If we can also make a financial benefit around addressing equity, all the better. But it's not our primary reason. So just kind of to summarize, and this was a very kind of whirlwind trip through some of the things that we do in the hospital. I think when I think about what works, one of the things that Angela and I were talking about before we started the webinar is legislation works. And legislation has been very helpful in ensuring things like safe workplaces. And safety now including freedom from harassment, freedom from workplace violence, the threat of threats in that constitute workplace violence as well. So, and domestic violence, having Bill 168, which has made made it important for us, if you know where you ought to know, that domestic violence is taking place in your workplace. So we have a very robust program around working with staff around domestic violence. We do a lot of safety planning, and we have a lot of staff come forward, or their managers come forward, because they see that there's maybe some warning signs that domestic violence may be occurring. And by doing that, we make we help those staff feel really supported. We make sure that they, have access to resources outside the hospital, around their safety at home as well as within the hospital, making it safe for them, but also for everyone in the environment. So those are just examples of, I think, the way legislation works. So it's important for us to work for that. It makes a big difference, and that's that accountability piece that's so important. So what works is, there's evidence. There's evidence that says that there are, and again, I'm just using that one study, there are many studies that talk about the impact of health inequities. And those in turn have an impact on cost, quality, and safety. And of course, healthcare providers are concerned and interested in that. We can, and hospitals and in your organizations, play a major role in addressing health inequities. And that's some of the things we've talked about. And I'm sure you have many other good ideas around what works and what's worked for you. Leadership support is absolutely critical. We have a new CEO at Sinai Health System starting today, and from what I've seen, they're very committed around health equity and very knowledgeable around it, and have been very supportive around that work in the past. Because his previous role was as chief of medicine, as physician-in-chief in the hospital. So that's great and really important that you have that kind of support in your organization. And also, Angela said, I'm going to quote you again, before we started, if there is a director or a CEO who's committed around this, it will happen in an organization. So it is essential that we get that kind of support. Data collection and monitoring, so, asking in some way, how is this doing? How are people feeling here? Are people feeling, and if they're not feeling okay, like what's happening for them, and then thinking about ways that we can address that. So focusing on that quality improvement, but also talking about quality. If you are working in healthcare quality is very important, and in all of our organizations, that if you address health inequities, if you have a staff, if you have a workforce that feels supported, treated with respect and dignity, and that, if there are mechanisms and good, safe places for people to go if they're feeling harassed or discriminated against, then you'll have people who are much better equipped to take care of patients. They're feeling supported themselves. And I'm sure all of us want to have a healthcare provider who's having a good day, and you want to know that they have all of that going on for them in their organization, all that kind of support and emphasis on equity and all the opportunities that could be available to them as well. So we do a lot of education, and I think that is a key ingredient. The education makes a huge difference. Even when we did domestic violence training recently, we got to train 1,000 nurses for an hour and a quarter or so around domestic violence around patients and themselves. We saw a very large increase in the number of staff who were coming to us around safety planning and to identify that they were experiencing domestic violence. So you have to do it over and over and over. And again, it not only if you have a stable workforce, if you've got a lot of turnover, you do as well, and new folks coming in, but you also need to do it to remind people. This isn't their work. For us in the hospital, it's ours, but it's not what everybody else is doing every day. They're taking care of patients. And then I think, being creative, because there is, when these people, again, those folks who are saying diversity programs don't work, well, it's not like there's this perfect place that we're going to find. We don't have a great example. We have to make this up. We have to think about what could improve equity for people in this organization. How do I get people to listen to this? How do we make this important and as urgent as everything else that we do in the organization? Colleagues, like having all of you out there kind of as folks who are interested in this, and then, working with other organizations, that any of the success or any of the the support that we've had as an organization has been also because we have wonderful folks in the community who are doing really great work, and who we can collaborate with and who we can work with on projects and help us to do even better. And then, finally, just reminding everybody that anything that we do to improve the quality and access for people who are in marginalized populations, that will, improve the situation for all of our patients. It will improve the quality of care for everybody. And finally, this is our health equity website and has all of those resources that I mentioned earlier, and it's torontohealthequity.ca. And you can follow us on Twitter. We would love you. Please follow us on Twitter. We love that. Thank you. Thank you so much. And I hope you have some questions.
Thank you so much for that, Marylin. I just want to warn you now, I'll be stealing some of this information and using it in future presentations because it's all good. And I was a little concerned at the beginning, coming from a health equity framework, that some of the folks who may be joining us that are not in direct healthcare or health services might not find it relevant. But as we were going through, I thought there was a lot of ways that we can adapt the material in terms of, the data collection and being an ally. All of those things are easily adaptable into any organization, I think.
Great. So if you have questions, I think, Margaret is saying it's quite relevant to what I do in post-secondary. Yeah.
Great.
So if you have other questions, comments, if you want to raise your hand and you have a mic, you can we can unmute you and you can talk, or if you have questions, you can simply put it in the chat box, and Marylin will answer the questions.
I'm also interested in hearing more, Margaret, around how how is it relevant and what you're doing in post-secondary around equity as well.
Absolutely.
So,
yeah.
Margaret, should I unmute you, and you could tell us a bit more about your experiences, maybe? Okay, over to you, Margaret.
Maybe she doesn't have access to a mic.
I don't know.
Oh, there.
Okay, we can hear you now.
Margaret, are you there?
Hello?
Hi.
Oh, I think we have some...
Squawking.
Oh,
I just wanted to thank you for the webinar.
okay. Thank you.
Thanks so much. Thank you for listening.
Of the topic to not only healthcare, but I have a number of colleagues sitting with me here right now in post-secondary
That's great.
and providing equitable services of equity for students and employees and campus visitors. So a lot of relevant information here.
That's great. Oh, thanks. I'm glad. Actually, that was where I was before before I was at Mount Sinai. So that's great.
Yeah. Mary is also asking if the webinar will be accessible to others who are not able to attend. I think we will make it available on our website, the Embracing Inclusion website. We'll post a link there, and we'll put this online.
I'd be interested in hearing, some of the challenges and successes that folks are having too. What's working for you, or where are you finding, where do you find it really challenging to make change in your organization? We won't tell anyone. I understand that may not be.
Suzanne is also saying thank you for sharing. Definitely practical.
Great, thank you. Thanks, Suzanne.
So I had a question when you were talking about the census and originally getting like 50% response or whatever.
Mm-hmm.
How involved was HR meaning human resources, in the process of doing this?
Very important. So I do work really closely with them around those kinds of initiatives, and so they were very, very involved. And I think our goal is to actually, when we bring people into the organization, that's when you got to collect the data,
Yes.
and that's how you and you make it just part of your normal kind of coming into the organization process, or as they call them, onboarding. So we work with them, we work with OC Health really closely, and we work with organizational development, but also, sort of throughout the hospital, it's very important that we understand people's work, and that we understand the complexity of getting change to happen in the organization. And I think in post-secondary, some of the challenges that you might find there is the sort of the space that people own. So owning your own classroom and having that be your space to kind of do your thing. Whereas in healthcare, the difference I found is that people are working in teams, and they don't have private space really very often, and not that a teacher has private space either, but I think just having kind of your own space to do your own thing, you're always interacting in healthcare with others.
All right, we have one more question from Maria, who says, if income is the least likely answered question from clients or participants, how might we encourage answering this question, given it's the strongest determinant of health?
That is such a good question. Some of the things we've thought about is how we explain the question to folks as well. It is interesting. I mean, it is such a strong determinant of health. Some folks ask that in different ways, but we think it's so important to get an answer to that actual question. And we do have the answer is not, you don't actually provide a number, you choose a range. And our ranges in hospitals are pretty substantial. In the community health centers, because of the population they're dealing with, who are, often have less access to money, they wanted to get more granular in their answers as well. I kind of think and hope that it will be a matter of getting used to this kind of question being asked. We're not used to this. We're not used to providing this kind of information. And certainly not in healthcare. And I think people may be sometimes worried that they're going to be penalized in some way. So am I going to be treated less than because I have less money? Or, what are you going to be thinking about me? Or nobody talks about money, and we don't do that in polite society. So I think there are a lot of barriers. Again, I think we have to get people used to being asked, and people can update that information at any time, but we also check in every 2 years. So if we have your patient demographic data, we don't want to keep asking it of you, although unfortunately if you go to another hospital or a CHC, you will be asked again, because we don't have the capacity of share, because of privacy legislation, we don't have the capacity to share that information at this time. So I wish I had a better answer. Maybe Angela has some ideas.
Just in thinking about that, I mean, I really like the whole we ask because we care kind of thing, and I think that from my experience, really explaining what the intention is of collecting it sometimes helps a little bit for folks to say, okay, yeah, I can give that information if I know it's being used for this, if it's going to help others, kind of thing, right? Just a suggestion.
That's great. No, for sure. And those posters are everywhere that we're collecting data that say we ask because we care, and we're trying to increase access and quality.
Yeah. All right.
Okay.
So I just got a little note in front of me saying, do I want to make announcements about other upcoming webinars? So for folks who are interested, we will be posting a schedule of upcoming webinars that we will be doing as part of our Embracing Inclusion project. For those of you who participated in the Embracing Inclusion, you will be getting those directly. For those of you who haven't but are interested in more information, you can always check out our website, embracinginclusion.ca, and that information will be posted shortly.
Okay, we have another question from Tej. I'm not sure.
Tej.
Sorry, yeah.
We both know Tej.
Okay. So Marylin, how do you keep the momentum and excitement among Mount Sinai staff for the diversity and inclusion work, since you've been doing this for a while?
Oh, that's such a nice question. Partly because they're great staff working in our office, and they're creative, and they're excited, and they're so committed and dedicated. And there are lots of other folks in the hospital who feel similarly passionate about equity. So that is very helpful. So it's around, so we need allies. Those of us who do this work, we need allies. We need folks who are going to support us around this, people for whom it matters. And of course, I mean, I own the prize. We're doing this because we want the kind of environment that we've been talking about here for staff, and also for patients and families as well. But I think one thing we try to do is is think about campaigns that we want to launch. Like, where do we want to, what messages are really important for us to get out through the organization, and how would we build a campaign, and what would that look like, and would it involve, so we've got training materials, we have communication materials, we have events that we might organize around certain themes. So sometimes just working around themes is a way of getting, and especially in a large organization, infiltrating certain messages throughout the organization. And I just think, unfortunately, there is so much to do. There's so much to do, and there's so much that, and there's also exciting new areas such as health equity that has really emerged in the past number of years that needs our attention, and that gives us opportunities to approach this work in different ways. So I think also getting together with colleagues who do this work in other organizations is so important, both for support, but putting your heads together, like, oh, how do you do this, and how do what's worked in your organization, what exciting things are you coming up with? So thanks, Tej, great question.
Thanks everybody for joining us. Oh, hold on.
Another question? No, that's it.
Thanks, Tej.
There is one.
There is a question.
What has been the greatest challenge for you or your team in your work? Greatest challenge.
Greatest challenge. Oh, I'm sorry. Why I'm not? Nothing's really coming to mind as kind of the greatest challenge. I mean, I think we're all challenged by the inequity in the world that we live in, and that there's no kind of door that shuts that out from the places that we work and where we provide care and service. So I think our challenge is really the growing inequality in our society, and how it can feel discouraging at times that any of this is kind of makes a difference. But I think so. I think our own sense of maybe discouragement can become a challenge, and so we have to, again, I think, just again on the prize, and let's try something different. Let's see what else might work. Who else do we need as allies? How do we engage more folks? Who else do we need to support and work with? So I think that's basically how we work through those. And I see another one
from Margaret.
And people who are dependent on them for care. So that's so Margaret is asking, do you want to read the question then?
Yeah, I have a question in relation to the questions asked about demographics and patients. Did you consider asking whether the patient are also carers? Do they have people who are dependent on them for care, example, children, parents with healthcare issues? So if you could just answer that in 1 minute.
So we don't ask that question to determine health equity, although I'm sure that it obviously has an impact, a very big impact on people. But that is information that is regularly collected by nurses and by social workers who are doing actually their healthcare assessment. So that information is looking at, what kinds of supports do you have when we discharge you, etc. We haven't asked that question in relation to health equity, and it is a great one, but as I said, we really wanted to focus on those that would have the greatest impact in helping us to determine health equity. But thank you for asking that.
So that's it. Looks like we're out of time. I'm getting the all end sign here. Thanks everybody for joining us, and thank you so much, Marylin, for coming in and sharing your insights and experience with us today. And everybody, enjoy the rest of your afternoon, and as Marylin said, eye on the prize.
Thanks a lot. Bye-bye.
Bye.